relevant, let me know and we can um, what people want to discuss as well. Um, so what I'll try and cover this morning is about COVID-19 and some of the effects on the mental health of autistic people and their carers or family. Look at a general overview of well-being, which is something we should practice all of the time, but it gets more difficult as circumstances get worse. Um, Also about what is mental health and specifically how it can affect autistic people and how to perhaps manage some of the common mental health problems. So these are some of the problems during COVID we found. Um, One is kind of discrimination. Although the disease doesn't know what it's doing, we find that there's increased rates in Black, Asian, and minority ethnic communities. And some of that we can explain by this is the group of people who are kind of frontline in public service, meeting people all the time. So you see there's a figure there of 53 NHS staff who've died in the pandemic. So far, 68% are from Black and Asian minority ethnic groups. But this kind of being public facing doesn't explain everything, because we find out of ICU patients so far, 35% have been from Black, Asian, and minority ethnic group. And that's a high rate considering this group only make up 14% of the population. So it's more, I think, than just increased contacts. And we need kind of more resources to go into that to understand it. And I think this is where the kind of discrimination part comes into it. It's a number of minority groups, including BAME groups, people with learning disabilities, autistic people, and all of the groups that seem to be more vulnerable in society. For our particular group of people, autistics, for a lot of people I know, there's been a loss of activities, work, college has stopped. People have found it very hard to cope with changes in their routine. There's been a lot of uncertainty and understanding. Um, People are finding it very unfamiliar, the world, and making sense of it, why it's happened. Is it all some kind of game? And one of the worst parts that people have tell me about and have to cope with is being scared and increased anxiety that something awful is going to happen to them, even for people who are kind of less at risk because they're not really meeting anybody to see. If anybody wants to read more, I've sent Mariama these slides to have a look at. There's a link to the Guardian article where those figures were taken from. There should be a picture of a book there, but it hasn't come up for some reason. We've done this free to publish book, and I'll send the link to Mariama. And what we've got is the experience of people with mostly learning disabilities, some with autism, and we've printed that. That's online at the moment. Sorry. But we're just revising it because there was a number of stories we missed out. And that's got perspectives from all over the world. We've got Austria, Canada, England, we've got Ghana, South Africa. So we try to be quite inclusive and not just think of our own experiences, but see how other people are looking at it from around the world point of view. And there's also some kind of nice pictures. So I'll send the link as soon as we've updated the latest version, which has also got the new COVID figures. This is just one of the little stories from the book, and I'll read it to you. And it kind of tells somebody in their own words how they're trying to make sense of the COVID. So it says, "Hello, all readers. I am Nathan. I'm writing about the dreadful occurrence of the coronavirus pandemic. Now, this is a tough time because for me, it is still going on. I am in your past and my present. It all started gradually. We heard it in the news from time to time. Then it became gossip at school. Then the teachers were acting strangely. Then everything went kablamo and my life was turned upside down. For me, the main kablamo was straying from the normal timetable. Because I am autistic, this made it a huge jumble. I found it really hard when schools shut down for the first time. Now, I bet you are thinking, why can't I go to school? Well, it is because it is horrible. It is like you get never ending homework every day, and then everything else went kablamo, starting with the house. We have just started with building works. This means a whole half of the house is unable to reach now. This meant we had to take everything out of that half and move it elsewhere. That meant because I used to work there with my mum, I got moved, which confused me to where I am going. Then we got delivered lots of stuff. Most of it wasn't even ours. Then we discovered our entire internet connection wire was under a pile of rubble. I was really sad as I rely on the Minecraft and Zoom to keep connected to the outside world. We also discovered that there was a wasp nest in the roof about the size of a large football. And now my sister has become attached to her bed. She became a teenager. I have no company but birds. Sometimes I just sit outside and talk to myself, imagining the birds are having a conversation with me. They aren't. My tortoise is a bit confuddled. Why everyone is always around? Because my dad used to go to work all through the day. And whilst we were at school, my mum was teaching in the end room. Since lockdown, my room has become messier. I think it is probably because I spent a lot of time there, as my bed is there and my bed is soft and nice to sit on. The whole family is getting to know the whole wildlife because as it is spring, we have a lot of baby birds and we are around a lot more because we are at home. I hope COVID-19 ends soon. So, as you can see from that story, it's kind of a lot of the pressures aren't just linked to COVID. They're kind of, it seems like for this poor chap, when it rains, it pours. Everything seems to happen at once. Um, kind of life doesn't kind of respect what you're going through and seems to pile on the agony when you're at your lowest sometimes. So for this chap, he kind of lost all of his friends, his internet, his links, and in a world where he just can't make sense of what's happening and trying to adjust. So that's the kind of reality for most people, and they'll get different degrees of these feelings. And so this is from the book as well. These are some of the things that help people. Um, Keeping occupied was one, if they did have interests, going for walks. And I know this was contentious at the start because people were almost forced to stay in and you was looked upon funny if you was going for walks in the park. But for some people, it's one of the only things that will help kind of calm them down. Another thing that people tried for the first time and reported was weighted blankets, which helped give people security. Um, and some of it, although they saw people online, they didn't quite understand it, but it still made them feel better because it was kind of reassurance that people were safe. And most people could do that, but there was a lot of people we found when we was doing the online stuff that couldn't access it still or needed support. And the other thing was having things explained, keeping things in proportion, what the risk was. Although it's a very dangerous and highly contagious disease, that there are things we can do to help. Another big thing was being able to see their loved ones, our support staff face to face. And that really had a positive impact on mood to know that people were there. For others, it was quite difficult. And in some groups with people like dementia, where people are looking through the window at people and visiting from afar, people just don't understand why people can't come in. You know, people are thinking that their loved ones are being awkward and don't want to see them. So it's different for different groups and different people, how the kind of contact or type of contact people have had has changed. And although people prefer face-to-face, there was a lot of positive feedback for technology being used, family and friends, just to see kind of relatives were looking well. And again, and although people can't understand why they had to meet like that, it was still better for a lot of them than not. Now, the figures, I'm not sure why that's not showing. What I'll do is I'll just try to get it up on another version. I'll come back to that one, but this slide will kind of show. I'm just trying to get back to the full screen. This is really how the different groups in, this is for mental health now, if we go on to the presence of mental health is different in different groups. Sometimes the presentation is different. Sometimes how likely you are to be mentally unwell is different. So these are some of the groups that are at risk. People with diabetes, for instance, are 3 times more likely to develop depression. Also, mental health problems are 3 times more prevalent amongst people with constructive airways and pulmonary disease. 33% of women and 20% of men with arthritis have comorbid depression, and an estimated 20 to 50% of all people with cardiovascular disease have anxiety and depression. So you can see that different groups will suffer at different rates. Now, if we look at people or autistic people, what we normally see is there's increased incidences of anxiety and depression. And I'll go on to those a little bit later to try and put in context, because not a lot of people will still diagnose these things in autistic people, thinking that it's part of the condition. But I think one of the biggest things that we have to do when talking about mental illness is we still need to educate a number of people that autism is not a mental illness. In the early part of the 20th century, autism was associated with schizophrenia and hallucinations. And it's not till kind of the early 60s, 70s, or even later than that, that autism is seen as a developmental problem, and it's associated with development and language, and not with kind of mental illness or delusions. I mean, still today, although we know that, we still kind of fail to agree sometimes on definition on what is and what is not autistic. So we know that autistic people are at increased risk of developmental mental health problems, and the prevalence of psychiatric disorder ranges between 16 to 35%, which is slightly higher. If you look at general figures just for mental health problems, we reckon 1 in 4 in the general population will get that. In other conditions, such as learning disability, up to 40% might have these conditions. If we look at specific rates of specific mental illnesses, then you'll see there is a rise in anxiety and depression in autistic adults, but also other developmental conditions such as ADHD and learning disabilities will also have higher rates of different conditions. Now, one of the main problems of recognizing mental health disorders is you get some kind of old attitude still prevailing, is that, you know, what's the use of identifying it in this group of people and other groups of people? And as a result, it can be poorly recognized, because a lot of clinicians who don't know autistic people do have a lot of difficulty separating what their day-to-day life is, their core features, how they are every day in their normal lives, from mental disorder. So it's almost like people are fishing to look for symptoms or missing symptoms of mental illness because they think it's part of autism. So for a number of people who aren't aware or know people from this group, it becomes a significant challenge. Now, if we look at how autistic people might present, and this is just in general, so people will be all different, we get children and young adolescents, they'll often present with more behavioral and attention problems. And why this might be difficult when somebody goes into a new environment, because a lot of the time the people wouldn't know what they were like before. And this is why sometimes people will assume that this is part of their everyday behavior. So a lot of the times, and we'll go into it a bit more to discuss, it is really important to be able to kind of put across, people really are only using mental health services because there is a need, because they're behaving different, because they're in distress. And if they were being normal to them, they wouldn't be asked to go into these services. With adolescents and adults, often the presentation is more of a depressive or anxious nature, but people may have difficulty expressing these ideas or these concepts. They may be strange, and you may see it through behavior changes. And sometimes this is one of the best ways to detect what's going on. So it's noticing that perhaps people are sleeping not the same, or people aren't eating the same. And also what we found is studies with children and adults, they've been found to be more vulnerable to depression than people with other developmental disabilities and typical developing people. In the older adult group, there's really even less research, and we don't really know much of what's going on. And this is one of the projects we're working on at the moment with Nikki Martin, who Mariama knows well, looking at kind of the quality of life of older adults across different communities. So hopefully in the next year or two, we'll know a little bit more and kind of increase the appetite for researching that group of people who are often missed. So this slide is really, why are people at an increased risk? Well, some will have different medical conditions which increases the risk, such as epilepsy. There may be genetic decisions such as kind of Fragile X syndrome or Prader-Willi syndrome. It could be neurodevelopmental disorders or conditions which we said like ADHD or intellectual disability, and these show much higher rates, or these groups with autism show much higher rates of mental illness. It could be people in poor general physical health. And also there's a kind of increased mortality in a lot of groups we go with, is that because the access to healthcare and other things are different, people don't tend to live as long, although that's kind of changing. I mean, it's still the fact, if you look at a number of reports, that people do tend to die earlier than kind of neurotypical people. So this is really about, why do people develop mental health problems? And the last bit is really, there's no one answer. And it's probably a number of factors. I mean, it's very rarely can you say this happened and that's when someone changed. In some instances, we can, but usually before any big major incident, there's something going on before as well, or people kind of start to change slowly over a period of time. So sometimes it can be chemical imbalances in the brain. It can be trauma. And there's a kind of lots of views. Some is it's the lack of money or privilege. So there's lack of self-esteem, lack of self-worth. All of these things, lack of opportunity. And so any kind of underprivileged groups, working class groups, any groups that kind of have that are kind of thought to be more likely. And it asks the question, it's kind of, why does it happen to some, why not? And I think this is one of the things that we don't know. But whatever's coming over, I think, there are lots of views, but we always have to kind of listen to individual views and respect them. Now, family well-being, as well as kind of looking after our children and relatives, there's higher rates of mental health problems in the parents of autistic children, it seems to be as well. And a family history of mental illness has been associated with um, autism in a number of studies. Um, and really, one of the big problems of this is it has implications for the whole family and the support networks, because a lot of times people will delay going and seeking help, just because there is too much responsibilities that they have to cope with day to day. And unfortunately, some people will kind of leave it too long until they become kind of um, too unwell and then can't do it. So any advice would be, whatever it is, um, always go and try and see someone, sometimes, or talk to people, um, because really it's keeping your network strong, and also drawing support from the network, and being open with people. Um, so these are slides that some people have said what makes autistic people vulnerable. Now, some of these things that make people vulnerable also make them strong. And sometimes we get non-autistic people telling people how they should behave and what's right and what's wrong. So isolation for some is good. It keeps them sane. It keeps them away from people. Isolation for someone who doesn't normally isolate, though, can be a problem. And also isolation, if you someone who normally isolates, then all of a sudden there's something going on that you can't understand, then sometimes the isolation might make it worse because you're not talking to people. So isolation on its own, like people will do normally, is all right, but it's kind of getting it into context. And I don't think sometimes people explain this, and all of a sudden you've lost an audience. Also, we get experience of being bullied and socially excluded. And sometimes I get this a lot. I find a lot of people tell me who live in residential homes that, and when you look at hate crime figures and things like that, sometimes it's people they know, and it happens quite a lot. And all of a sudden, people take it as part of life, but because it may not be physical, but it's still something that gets them down, makes them unwell. Um, Also, sensory issues and communication difficulties, going somewhere new where people can't understand you. If you've got a different way of communicating, can be difficult. Um, Ability to work. I think sometimes we don't spend enough time on people's aspirations because, for a lot of people, it's so difficult to get a job anyway. And also, like, there's a lot of people that won't give people a chance, whatever equalities agenda is out there. The real case, people do find it very difficult to do jobs that they could do quite easily. Also, for some people, it's the ability to live independently. And I think that it's not that people can't live independently, is that often there's a lack of support services. It's across the board, not just for autistic people, of people independent. I mean, I can give you an example. Even if someone's discharged from hospital, I mean, the amount of people you will hear about saying, well, they discharged them over a bank holiday. There wasn't enough medication. The nurse who was coming in didn't know what to do. So there are all these things. And mainly it's not that people can't, it's because there's not the support there to do it. Also, sometimes kind of life events. And we get this as well a lot more for people in residential care. So we're not talking about just your normal life events of death or bereavement. Sometimes it's just losing friends or staff people kind of identify with. Because there's a high turnover, people don't normally stay in these jobs very long, apart from a few. And when you've made up relationships and trust, it's very hard to keep doing that again. It seems like you're kind of kicked in the teeth, because it's not a real friendship when people don't keep in touch with you afterwards. And this is what kind of people tell you what friendships are, which is the correct way. And some of this may create kind of depressive episodes. And I think it's sometimes, I think it's any change in life, however small we might see, is sometimes, you know, we've got to remember maybe vulnerable times for certain people. Now, there's some links there, and these are just some of the mental illness we're looking at. So depression is the most common, um, done by low mood, hopelessness, loss of energy. We all get depressed from time to time, but there's a clinical depression as well, where you'll have a low mood and it'll last for 2 weeks or more. That's what will happen if you go to a doctor for a diagnosis. Um, Also, it comes in different forms. It can go from mild to severe. So mild depression, which most may have experienced or think about, is usually you can talk to people about it, and that's what will be done. You know, it's not necessarily having medication at this stage. And in total, about 20% of people who do get depressed will kind of come out of it with no intervention, or it will just go. Anxiety disorders, which are often missed, are kind of different, and they often go with depression, where you get this overwhelming sense of worry, panic, dread. Um, and for a lot of people, don't understand it. So when you get someone with anxiety disorder, if they're not understanding it, what they'll do is explain the physical symptoms. Oh, I'm sweating, my heart's racing, I'm going to die, I'm going to faint. And it's up to us to kind of, if we're getting these similar symptoms all mixed up together, to kind of put the pieces in the jigsaw, um, and then kind of help people. And I think, and this is what we said at the start, in terms of mental well-being, it's good to talk about these things so people do understand where there's any kind of difficulty. Psychotic illnesses or psychosis, these are things like schizophrenia. Um, Often the people's reality changes. They sometimes may hear voices, see things that others don't, or they may feel paranoid. But all of a sudden, the main difference you'll see is that you're not really seeing the same things there. Some of it may be quite bizarre, but some of it might be quite subtle. So um, people, you can really only have kind of delusions, which are false beliefs, in line with the experience you have. So if you're kind of very intelligent, you can have the big space station and aliens and galactic genetic kind of delusions that these are invading us. But if you kind of less able, then it will be around your experiences. It might even be like, I own all the shops in the high street, or I'm a big man, because it really goes with the level of experience or what you actually see. So there's some links there of mental health organisations with some good resources that are worth looking at. And what I'll do as well is I'll try and get some kind of pamphlets of both not easy reader plus easy English. So um, for people who are kind of not doing this stuff every day. This is about sleep and anxiety. Um, what don't know much, but what we find is sleep problems are commonly reported in children with autism. Typical difficulties include onset of sleep, settling down, and night waking. There's very little done in adults, but what there is kind of talks about insomnia or increased sleep or people waking up in the nights. In terms of anxiety, anxiety disorders and OCD can be difficult to identify. And sometimes people will mistake rituals for OCD or the other way around. And so OCD can often be missed. So remember, OCD will normally be something quite different to what your person's normal routine is, even if it is repetitive. So what we get is people therefore often assume it's part of someone's autistic behavior. So what we see, adults with ASC and comorbid OCD engage in significantly more checking, ordering, and hoarding than people with ASC. So it's a difference in behaviour. There's more hoarding, there's more checking. It's not normally. Excuse me one moment. My dog's just chewing up me cushion. Sorry, I'm back. So expressing mental health. Some people are more or less likely to directly express feelings of sadness, hopelessness, or low self-esteem. Some people don't realize the kind of relevance of feelings. Also, people may kind of show less emotion or be flatter as a normal result, so sometimes this may get missed. Also, the changes, as we said before, can be subtle. And because it's subtle or it doesn't seem to be affecting the person, or they're not expressing it, we can often underestimate the severity. One study of self-reporting depression revealed, looking at the symptoms of anxiety or depression, that the autistic people expressed more symptoms when they were asked to report than their parents did. So they were both asked to do the same sheet, and what we found was that parents often underestimated the kind of feelings or symptoms of anxiety or depression that people were seeing. I think this is often because people are more likely to keep it to themselves and hide it more, rather than people, not caring or doing stuff, because it's not something that we kind of ask every day. Well, say you're all right, but if people are thinking, well, I'm feel all right, and they're not really asking about this, they will just tell you they're all right. So even with the best will in the world, this happens. So one of the big things is sometimes people's core features, whether it's kind of rituals, isolating, what you see is a kind of worsening of these, or people get more transfixed. And that's another indication that somebody may be kind of feeling depressed or anxious. It's just subtle changes in normal behavior that all of a sudden become more pronounced. So when we go to the assessment, of course, we have to have confidentiality, but a lot of people that I'll support, I'll ask, do they mind me talking? And that's not talking for someone or talking over them. It's about adding to their story if there's bits that you think are important that they'll forget. And I'll usually discuss that more with people so people don't feel undermined when we're in a surgery or a doctor's. So what we find is that when we get an increase in whatever traits or behaviors that seem to be normal, or they become so pronounced under stress, it can be difficult sometimes to differentiate them from symptoms of mental health. So it may be that they're becoming more stressed, but it may not be that they're kind of mental illness at the same point. And also we get features of ASC may overlap with symptoms of a range of mental health conditions, which makes it difficult to identify. So some of the people that I've kind of known will have kind of quite rich fantasy lives, which kind of keep them in order. There may be a starship planet, they may be a captain. It's something that they do, or they may kind of have tics or rock or something that keeps them calm. So sometimes with the fantasy, I've seen in some cases that people have mistaken this for delusions, and that the person actually believes the stuff rather than recognizing it. It's just the way that kind of people cope. It's just a kind of bow to their life where they kind of talk about stuff. So a lot of the time when you're supporting someone is, I suppose, these are very basic but worth kind of reiterating, is to use specific and clear language. And sometimes either the best will in the world, even people who are aware, will go into jargon. And sometimes it's good perhaps saying, you know, can you repeat that? Can I understand that? Also from the point of view from professionals, check that people have made clear the purpose of the assessment, because sometimes it's not always apparent. People only listen to the bit they want to because they're expecting an outcome. I remember once when in a hospital setting, we was discharging someone and they thought they were going back to Stockwell, and it was Stockton in the north. And as we passed out of London, they become like extremely upset because nobody had bothered to check that they understood where they were actually going. Also that people will get bored, or it'll be too stimulating if interviews are too long. So sometimes it's good to talk to clinics before, or surgeries or hospitals, and talk about any child's condition or even adult's condition, and saying these are the bits they find difficult, you know, do you accommodate for this? And it's also perhaps when choosing practices, you know, kind of ask what services and what adjustment they make for people. And one of the things in these kind of high pressured financial times, people try to rush in and out, and you get 10 minutes appointments. And for a lot of people, this is kind of not good enough. You're really only just going to be able to meet people in this time. So it's kind of seeing what they offer and can they take more time. And it might be even visits familiarizing people with different environments. There's loads of different things people might respond to. So coming back to mental health, we said earlier that there are 3 types of depression. So mild depression is you'll get some impact on daily life. I suppose one of the examples you get, if something's on your mind, you can't get it out of your mind. Wherever you're there, whether you're sitting down, it just keeps coming back. But after time, you can go, and parts of the day it goes away. Moderate depression is, there's going to be more of a significant impact on daily life. You're going to find it much more harder to get up to do the normal things. And in the severe cases, daily activities are almost impossible, until in some cases people just kind of stop, stay in bed and won't do nothing for themselves. And according to how severe the depression is, that'll be the treatment. So more severe, you'll get, moderate to severe, you'll get kind of drug therapy as well, that will go on to kind of lift behavior. But these will take a bit of time to work anyway. So the older antidepressants will take up to about 2 weeks. Well, I think now that you'll see some kind of, hopefully, lift in a week or so. But usually it's the people with severe are the ones that, if anything, will need to go to hospital. It's just because they are unable to care. The others, it's the mild would be more kind of GP, primary care, whereas moderate, they may kind of refer to a psychiatrist as well, and you may have some community input. So what are the signs that suggest someone may be depressed? So it may be persistent, sad, anxious, empty feelings. Often there's guilt where they shouldn't feel guilty about anything. Worthlessness, helplessness. One big sign is they lose interest in hobbies or activities. And in autistic people, sometimes hobbies and activities are the kind of center of their life, their interests. So this is a big kind of warning sign. Tiredness and loss of energy, difficulty concentrating, remembering, making decisions. So you often put things off, or, you know, when you're going to do that, things never get done. Insomnia, early morning waking or oversleeping. And this is a bit of a kind of, there's myths around sleep. It used to be that we'd say if you don't sleep, you're depressed, but also oversleeping is a big problem as well. Change in appetite. It used to be say that we didn't eat when we're depressed, but again, some people overeat and they'll put on weight. There may be thoughts of death or suicide, which have to be kind of taken seriously. And there'll also be physical symptoms such as headaches, digestive disorders, chronic pain. And a lot of this is a kind of manifestation from the stress. And again, when you hear people talking about these physical symptoms where you're not really sure what the cause is, you know, there may be some kind of underlying mental stress. So doing this, it's really each person as an individual. So everything we're talking about is something that may happen or could show. So it's everyone will experience all of these kind of mental illness or mental health problems differently. So one of the big things is to help the person recognize that there is a problem, being able to encourage them to talk, make sure you monitor things like any kind of negative thoughts or suicide gestures. Also, what you can do to help the person start talking and what are good things to do or say. The one thing I would usually do is help someone put a diary of their thoughts or their eating or their weight, because sometimes it's difficult to remember over time periods. You know, even if I go to the doctors, they'll say, have you been sleeping? If I say no, it might be hard for me to remember exactly how long, because usually we may have left it too long before we go to the doctors anyway. But sometimes a diary is very good because you can show exactly what's happening, what's the behaviors has been changing. So what we can do is, sounds obvious, but try to cheer them up, but don't overdo it. Sometimes we go over the top. We try to cheer someone up, we get a good response and we keep at it, and then we overwhelm them with our kind of good nature and presence. So it's kind of being there, but it's a hard thing to do not to overdo it. Also, listen, don't dominate conversations. Give advice, you know, when it feels right, not just all the time and kind of take over, because you want to hear as much of the story as you can. Because it may be that there's bits of it they forget that you may be able to help them report. So that's where you kind of try to hold as much of the get a positive conversation as well running at the same time. Another thing is to do, which it can be very hard, is don't snap at the person. Families are so close. It's like I say it to Mike, you know, it's like, don't be silly, don't do this. And it's not that we're meaning harm, but it's like we can't help the way that they're feeling, but we've kind of got to acknowledge that as well. And sometimes that can be hard because we don't understand it, because why are they feeling that way? Sometimes there's no reason why they feel it, they just do. And also sometimes is we might make a joke about the matter. It's really like saying, oh, come on, and that will make them funny. But sometimes they'll think you're not taking it serious, and you might lose trust in terms of them talking to you about it. So careful not to kind of make a joke, because most people don't do it to take the mickey, they do it to kind of help and lift spirits, but a lot of people take it a different way. So be careful what you say to a depressed person, and also don't try to take on the problem by yourself. If there's help, or try and find help wherever you can, because what happens as well is that people become overburdened themselves, and then they become restricted and can't be doing. Also, you know, give time. Don't be nosy all at once. Don't make them tell you everything. You know, if they don't want to discuss something, kind of wait. Don't try to kind of force people to talk about it. Knowing you're there is a big help. I think it's like, you know, um, when you lose someone, you might not want to talk about it all the time, but knowing that someone is there and you can talk to them is a very positive thing in life. These are kind of different types of depression that you might see. Atypical depression is just like a depression that presents very differently. You might get people who look very happy all the time, but inside they're really depressed. Um, Psychotic depression is when someone also starts losing reality, and it may be they think their insides are going, or they might start getting false beliefs about their body. Um, Another type is seasonal affective disorder, and this is the one where people go abroad for 6 months of the year, where it's a kind of lack of sunlight. They become depressed in the winter months. And there's also things like postnatal depression for mothers just about to give birth or after birth. So there's some of the other types that people also might suffer from. Um, Anxiety is the next illness we'll go on to. This varies from individual to individual. We all get it. For some, it's good. For most of it's good. It will keep us aware about danger, and it's appropriate. It will keep us on our toes. We'll get it when we go for interviews or jobs or in difficult situations. But this anxiety, it may be triggered by something that someone's scared of, or it might be triggered of nothing we can see, or kind of overthinking things to come to conclusions that won't happen. That, you know, they may die, something might happen, what's not going to happen. So these are some of the signs that you might notice. People might start feeling worried a lot of the time, have feelings of dread, something terrible is going to happen. They get tired, but still have problems of sleeping. It's just because they're so kind of hyper awake. They're looking around all the time because they're really scared that something's going to happen. So all of a sudden they have to keep awake. There's difficulty concentrating. A lot of that is because your mind's racing. You're worried so much about the anxiety that you can't do anything else. Another thing people don't associate is often people can get irritable, people can snap, um, and sometimes, you know, it may get so bad that people sometimes can kind of lash out because all of a sudden, whatever someone's done has caused that anxiety to increase within them and it becomes unbearable. Again, we get the physical signs, the stomach aches, the rapid breathing, dizziness. Um, and these are usually the ones that people will come out first. The other time is a kind of change of behavior again, and people doing stuff that they don't normally do. Um, so what can you do? Help the person to recognize that it is a real problem, um, that they're not suffering or overacting. And one of the difficult bits is we have to recognize what they're feeling is very frightening and the sensations are real. But at the same time, we kind of have to tell them that what they're thinking is the worst thing might not happen. So I'll give you an example. Someone has a panic attack, their heart starts racing, and they think, I'm going to have a heart attack, I'm going to die. Now, although it's very frightening, it's kind of, we're trying to talk the person out of that, whether it's we kind of get them to deep breathe or whatever we're trying to do. But what we're telling them is that the heart attack won't happen. You know, this is not really what's happening. This is just how you're feeling because at the moment you're having a panic attack. So what we have to do then is kind of, when they're feeling better, is to give them more information and educate them about the anxiety and panic attack so they know what to do the next time it happens. And then people are more ready for you to talk them through it. Because after they've had one, you can always tell them, look, it didn't happen. You know, this is a pattern of things that are happening. And once you've got some help, you've then got a hook to help people understand how they can help themselves. Another thing is to kind of encourage relaxation. There's different things you can do. General anxiety is different to panic attacks sometimes. They can occur anytime, even during sleep. Nightmares may wake you up. As we said, they may feel they're having a heart attack, but the terror that the person experiences is not in proportion or doesn't reflect the true situation. And it's also often unrelated to what's happening around them. You can't see why people are anxious, but they are, because you're not experiencing the same thing. And they're just at the bottom are the symptoms explained again. Psychosis. Psychosis, one of the big issues is that self-harm or kind of suicide in this group, and a lot of people don't take that seriously. It used to be that kind of 1 in 10 people with schizophrenia may commit suicide. And sometimes the warning periods for this is sometimes when they're better or feeling better, or they're lucid, they're out of the main illness for a period, when they get depressed, or sometimes when they're out of touch. But it's one of the things that are often underestimated and not thought of. We often think of schizophrenia as something quite dangerous, something doing, but most of the people with schizophrenia are more kind of not dangerous to other people, but more dangerous to themselves in terms of kind of picking stuff up. These are some signs you might get. Exaggerate things or minimize things. Different things can happen. There may be hallucinations. Also, when the illness becomes chronic, people become slower to move, think, speak, or react. A lot of people, if you sometimes medication will add to this effect. People may have false beliefs that are not incoming. That we used to. A lot of people do seem to get quite religious beliefs, and sometimes it's always checking these out because they're not always delusions. I mean, people worship, pray, whatever their religion is, in very different ways. Even within the same religions, there's lots of differences. So in terms of involving community, it's kind of getting, if they're kind of very seriously religious, is getting the people from their kind of community or congregation and seeing, is this normal within your kind of daily practice? Is this how they would act, or is there something over the top? You know, are we understanding it properly? People will withdraw, agitated, not care. Also, they'll find it difficult to organize their thinking. And thought disorder is a big one, that sometimes people are sticking things into their head, thoughts, or taking them out. And so they have difficulty in understanding things and may become paranoid. But usually what you'll see is a kind of, the person becomes almost, you can't put your finger on it, but you think this behavior is quite strange initially, and then you'll get more major symptoms coming out. And for those who kind of don't get help, or the disease becomes chronic, then you'll get a much more negative presentation where the person just finds it very difficult to look after themselves or to kind of self-care. But the kind of the florid or the kind of severe hallucinations are kind of have gone by that point. One thing to do is make sure medication is closely monitored. For some people, this it's not monitored enough. I know someone that we work with, her son, whatever the mother says, the doctor won't take advice. But they know that during this, 3 weeks into an injection, the person becomes more unwell again, and there's a week where they seem to be unprotected. So if you make sure it's monitored, and although you don't think you're being listened to, it's that bit about diaries, collecting evidence to kind of show what's going on. Then people can't dismiss what you're saying if you've got hard evidence. Concentrate on the person's emotions and feelings. Also be very patient. Although you have to tell people that it's not what you're seeing, to them their beliefs are very real. And you will kind of lose trust if you kind of, at least, you know, although you don't believe them, you have to believe what they feel. Bear in mind that there's people with schizophrenia that do fully recover. And as we said earlier, don't collude with any hallucinations and delusions. It might, you know, it's something like, it may be what you're seeing, but I can't see it. And there's ways of doing that, and there's ways of introducing that. And it's usually kind of, you know, when a person's calm. It's a bit like when someone's agitated, you don't tell them what you'd like them to do then, you wait till they calm down to discuss it, because you don't want to provoke any additional worries. Bipolar, what you might notice, this can come as just depressive episodes sometimes, or the other bit is being quite high, paranoia. They're overactive. People may become promiscuous, very grandiose, think they're the king, can do a lot more than they want to do. But also there's long periods of stability between episodes. One of the big risks here is people getting tired, particularly when they're high, and exhaustion. So people just forget to eat. It's not that they have no appetite, it's just they become so hyperactive that the normal day stuff goes. Also remember that someone's ill, again, the mood diary. And if people you know have had episodes or suffered from this, it's the same with any psychosis. Try to recognize the early warning signs, because there may be triggers or something how the person behaves differently just before an illness is coming on. Again, similar advice to all disorders: concentrate on emotions and feelings, and don't collude with any kind of grandiose ideas. You know, you're not the CEO. So I won't kind of keep you any longer with the slides, but I'm happy to chat, have questions, and I'll stop the share now.
No.
Are you there, Mariama?
Hi, Eddie. Can you hear me now?
Yeah.
Hello?
Hiya.
I'll use this one. You just unmute it. It's not working. Oh, God. Can you hear me, Eddie?
I can hear you.
Mine is unmuted. Yeah, you can hear me. What's happening? The screen is frozen. All right, I'll use Mr. Costa's phone. Can you hear me, Eddie?
Yeah, I can hear you.
I can't hear you.
Doesn't seem to be, my computer does not, it's like the screen is frozen. Hi, everybody. It's time to ask Eddie any questions we would like to ask, please. So that's what I wanted to say. If there's anybody with a question you want to ask, please. I want to show everybody.
I'm looking at the chat. I'll send a link to the book about in the next week. We're just going to send it to people who've made contributions to check this time. So it's okay. So it'll be a week or two, I'll send that. But I've already sent the slides to Mariama, and I'll the email addresses people have given me, and I'll send them individually as well. I suppose while we're waiting, does anyone want to ask anything?
Yes.
Hi, yeah.
Hi. Yes, we live in Southwark. So what services do you think is available for people suffering from mental health, especially autistic children?
It's a very difficult one because you know yourself that although the government's kind of prioritised screening and all of this, there's very kind of little services I can see apart from the local ones that you'll probably know of in Southwark. I think sometimes the best port of call is the GP first to do that because I'm not kind of really an expert of what the actual services are available. It's been about 10 years since I kind of worked, and that was mainly with adults.
Okay. Okay.
Usually the GP are the ones the kind of first port of call to get a referral. And then they'll usually send to a kind of child psychiatrist to see what the issues are if they feel that they can't treat them within the clinic. But I'd always start with the primary care because you kind of get no luck trying to go higher what you think you need.
Yes, yeah.
Because it's a funny system. So always use your kind of GP as the opening part. And as I was kind of saying earlier, trying to get a good GP who's kind of understands the issues, what they can do, where they go above and beyond. Because sometimes there's a lot of people that come in and they look at you like, so what? And they can't see what's happening.
Yes, yeah. Yeah, because I tried contacting the GP and most of them said they will have to wait till the lockdown is over so that they can refer my daughter to a specialist to see him. But at the moment, most of them are shut. So we just like
yeah, no, I think that's everyone at the moment. And the unfortunate bit is people have to be in crisis.
Yes, yeah.
Before people will do anything, and it's like it's almost like that everybody's forgotten, and if you're forgotten anyway by most people, unfortunately it seems like we're further down the queue. It's a bit like when they looked at rates of people dying or people contracting the disease, they put in all people with autism with learning disabilities. And we know there's a lot of people with autism with learning disabilities, but that's not the whole group by any means.
No, it isn't.
And so in terms of COVID, there's a lot more that we need to do to understand. So
yeah.
I think it's kind of soon as that lockdown ends and you can see a window.
Yes, yeah, hopefully. Thank you.
But it's not easy. And I think, you know, it's kind of support where you can. I think, no, Mariam, I know this group's a kind of a good source of support for people.
Oh yes, Mariam's group has been excellent. Excellent in helping. Thank you.
Thank you back, Mariam.
I'm going to use this one. This one is causing a lot of noise. Oh, hi, Eddie. Sorry, my computer is not it's making some trouble. My question is, we meet a lot of parents who ask the question about, you know, how autistics can be talking to themselves most of the time.
Yeah.
So I've had a few ask, I know it's not a mental health issue. Sorry, I need to go outside to make this clear. Lovely. I know it's not a mental health issue, but the question is there something one can do to minimize the way they talk to themselves endlessly? Or is it something that I know it makes them, because I've spoken to my son about it and he says it's his own thing and it calms him down. It helps him to get things in perspective. But on the broader side, or on a theoretical part of it, what do we do in terms of people who they just enjoy talking to themselves in a stimulating way?
I know what you mean, exactly. I mean, a lot of autistic people I kind of know, kind of academic autistic people, will say it's just like it's the neurotypical world trying to force you out of kind of into abnormal behaviors. I mean, what I would say is that, you know, to not bring attention to yourself, show, you know, where are you doing it? Be conscious of who's around you. I think at home, you know, there's no issues, but the kind of, you know, it's just kind of letting the person know that some people might not see it as that. And also, it was a little bit I was trying to say, when you're going for a psychiatric assessment, sometimes people will take that as that you're talking to voices, which, you know, is not the truth. It's not true, but that's what some people will see. And that's why sometimes it's so important, because people will swear blind, that's what they've seen. But, you know, it's something that people do every day. And it's an important part of calming them down, or calming themselves down. I mean, if you try to stop it, it's just, you're probably going to give them more stress. And I think it's a bit about letting them do it. So some things we'll do is, like, people who kind of rock, may get a lot of attention outside, but it's saying, like, if you need to do that, find somewhere private where people aren't going to judge you or look at you, you know, or do it in an environment where you're comfortable, where there's people you know. And I think that's the bit, but I wouldn't stop people doing it. But it's just kind of making them aware of how other people might see them, because that might have a bad effect on them. Not because they shouldn't be doing it in front of other people, but they kind of should be aware of how other people might react.
Thanks, Eddie. Michael would like to ask a question.
Yeah. Well, yes, I have a question to ask, because I've been waiting ever so patiently. Am I the only person who's having to deal with the current COVID situation? No, yeah, sorry, I'll ask the question. Let me repeat that question. I'm wondering why including me having to deal with this whole current COVID situation? That's what I want to know.
So I missed the first part. It's bad connection.
Yes, there was a bad connection. Sorry, I better ask again. Yeah, I better ask the question again. Why are we all dealing with the current COVID crisis? That wants to know. Hang on, my video has been stopped.
Okay.
Where was I?
You was asking why we're all dealing with the current COVID situation.
That's right.
Yeah, I think it's just one of these unfortunate things that happen every 100, 200 years or so. I mean, one of the first ones was probably the plague, which was kind of a bacterial disease. Then we had the Spanish flu in the war. And these crises come every couple of hundred years or so. This one's made by a particular virus, which is very contagious. And so why we're dealing with it really is to try and stop that spread and also kind of increase or decrease how many people have it and how we can pass it on. So in the hope that it will diminish. So it might be a lot better once we do get a vaccine which is available to people, because people
Definitely. Sorry, what was that? Yeah, I'm finished for now. Thank you for asking.
Thank you.
Just forgot what I wanted to ask. My hand is still there. Can I?
Yeah, I can hear you.
Yeah, sorry. I had put out my hand on the system. Anyway, I just wanted to buttress the fact, the answer you gave for trying to stop people who repeat after themselves or who talk aloud, you know. So I was just saying that it's the same thing as the way some autistic people will say what they think. Just, you know, suddenly something will come, or you see somebody who is very, very big. You say, "Mommy, why is that woman fast?" This is somebody thinking within. What he's thinking within, it just comes out within. So it's hard to stop somebody to think, you see. So if we start stopping them all the time, they are repeating things to themselves, we put them really under pressure.
Yeah.
So I do agree with you. So we parents who have young people who do that, even if you are telling them, it has to be very, very mild and, you know, with tender care in order not to put them under pressure.
No.
And they will decide, they will go and think about it, because we think when we talk, they don't think about it. No, they will go and think about it. And then you see them deciding for themselves to minimize it.
Yeah.
Especially those who are capable of, who are at that level.
Yeah, and I think it's right. It's kind of making people aware what others might find angry or insulting, but it's not chastising them at the point. It may be kind of helping them, because I know example in my own family, my niece died and her brother's autistic, and well, you can imagine my uncle's upset, and they had a row before her death, and my autistic kind of nephew went, what are you crying for? You didn't like her anyway. Just thinking of the last thing. And it's that kind of thing that it's like, oh, and as much as I know, or we all know, it still shocks us sometimes. But it's like, again, it's finding the right place to say perhaps something different, or not to kind of fall into that trap again, because it's not that they believe that, it's just the sense they've made of it, of the situation.
Well, I also think it's time that we, who the non-autistics, should learn how to accommodate if you know that this person might say something like this.
Yeah.
So if you know that this person is like that, when they say it, it will not hurt you.
Mm.
But if you keep getting surprised all the time, every time they say something out of the ordinary, then we are the ones that have the problem.
It only becomes an issue sometimes where we find difficult if it's people we don't know in the street, or we may not know they're autistic.
Yeah. Thank you.
Any more questions from anyone?
Yeah, I have one more question. I might be very far away, but I've got one more. I have one more question to ask.
Okay.
The question is, when will everything be back to normal after the COVID-19 pandemic? The question I would ask.
I don't have the answer to that one. I know that they're talking about us at least getting a bit of normality on December the 2nd if we come out of lockdown. But I think they're gonna look more towards the kind of middle of next year before we get any more kind of normality, because even if we do get a vaccine, we've still got to roll it out to different groups of people. So it's a difficult one, and it's one that kind of changing all the time. So we have to listen to the scientists really and see what they're saying.
That's all.
If we don't have any more questions, Mercy still wants to ask a question.
Mm-hmm.
Yes, Tom can ask a question. That's 2 questions.
Hello.
Hello.
Can you check my hands? I always put hands up there on the system. Anyway, what I wanted to find out, if there are plans, or are we in any way trying to educate people? For example, when you were giving the talk, you said something about the balance between autism and mental health issues when people are assessing, people on the spectrum, on either under the mental health or MCA. Are we in any way trying to educate people? If professionals, yes, because as I see it, people who are living with the experience, like, everybody there, know a lot, but they don't, maybe they don't realize it. They know a lot about autism, mental health. They can't tell if their son or daughter is veering towards the other end. Yeah. Because it's a very thin line when people go to assess under the mental health to differentiate between the person having learning disabilities, autism, and displaying mental health, issues. So the organization, are we in any way trying to educate those professionals?
I mean, we should be training, but there is a lack of training around. I mean, we've got the Oliver McGowan mandatory training there starting up now. I know I used to work for South London and Maudsley a while back, and I know there's a specialist learning disability team and in there and autism team, which I used to work for years ago. But getting referral to those services is very hard. One of the biggest complaints that we used to have all the time was that we saw people in need, but the cut-off points or eligibility before people come in was kind of a real problem. And it was a bit like we were saying earlier with anything, that why do we have to wait for people to become into crisis before they are seen? Whereas something quite quick, and meaningful could help, and save a lot of resources in the meantime, but also just help the community to kind of function better in society. So although we're getting improved, it's not as much as it should be, I'm afraid, the kind of training, and it's just like it's just kind of in little pockets as I can see at the moment, or some of the training you see is not really appropriate either, that some people give to staff even. It's more kind of, so if someone talks to you and gives you a list of autistic symptoms, everybody thinks that everyone with autism has these. They don't have empathy, they got no emotion, and anyone who knows any autistic people will know that's rubbish.
Rubbish.
It may be shown in a different way or expressed differently in some people, but it's, but people go around with these misconceptions in their head of how people behave and react because they've just read the book. So technically they might know a lot, but they know very little of the real world, how people are.
Yeah, that's why I think that those who have lived the experience can teach the professionals a lot. For example, when they are doing their approved mental health professionals training, if they can come in to explain or to ask, how do you do it? Let's say, what do you look out for? Where do you think there's a cutoff point to let us know if you are going to section my daughter or my son as having mental health issue, then I will tell you, no, this is how he's been behaving and this is how he is, and nothing has happened. So I'm just asking if you get the opportunity, if you have the opportunity to go into these trainings.
Yeah, I mean, South Bank, the university, in our nursing courses, we have kind of carers and people with learning disabilities, autistic people coming to do parts of the training. And we find particularly more with the learning disability students, a lot of those have background with people with kind of lived experience or experts by experience. So they come into it for kind of very genuine reasons. It's sometimes, so I think there's less in some of the nursing fields, but not all, because if you look at kind of general hospitals or other hospitals for physical health, you go in there and there's kind of less awareness. But I know in the courses we do for mental health and learning disabilities, we do engage people. But it's also, you're chipping away at people's beliefs because there's a lot of people with who come into whatever professions that they come into the beliefs they come in with, and a lot of it is not that it's bad, it's just that they don't understand things, so they come from a different point. So some people need more exposure than others, I think. It's a different stuff. So I think rather than just the 1 or 2 lectures, we need to kind of theme it through the whole program. So it's a way of working, people are listening to people all the time rather than the kind of just getting a token person in here and there to do it, because it's only doing that way where you're actually working with people that you can learn about people, rather than, because you can still presume after the odd lesson, but I think it's got to be kind of done throughout. I mean, one of the projects we're doing at the moment is peer mentoring people with autism and learning disabilities to teach mental health to their peers, and also they become the trainers as co-mentors. But yeah, I think you're right, there's just a couple of things that are happening, but there's a hell of a lot more needs to be done.
Thank you very much. What I was really trying to aim at is those people who are there who do the Mental Health Act assessment in order to, who deal with the Mental Health Act, you know, and if they are going to section somebody, they are training, they have consortium that trains them. If we go through them to let them know if they are doing their, you know, those lectures they do 3 times or 2 times within the year, if someone is invited to find out how really they get to that point to know the difference between where autism stops and where mental health starts.
Yeah,
So
no.
that's the thing. Thank you.
Yeah, no, that's a good point.
Is there anybody else with any more questions? If not, Eddie, I want to say a big thank you to you for doing this training this morning. Thank you ever so much. It's unfortunate my computer has not been working properly, so I'm not able to use it, except I have to use Augusta's phone. But really, really grateful, and it was really, really intense. Or the content was a lot, and there's a lot to learn. So thanks a lot, and I will get in contact with you again via email, and I'll see you as soon as possible. Thank you so much. Thank you everyone for coming.
Yes, thank you everyone for.
You're welcome.
I'll be waiting for the email with the handouts, the outlines.
Yeah, I've sent it already.
Yes.
Some of the slides, and I'll in the next couple of weeks, once we've republished the book, updated it, I'll send you the link to that so everyone can download.
Okay.
Oh, fantastic.
All right then. Thank you.
Then. Thank you ever so much. Thanks everyone for coming.
You're welcome.
Thank you. Bye.
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 Bye. Bye. I said I should be waving to you.
I've asked all the
Bye.
questions.